Hello again, and welcome to another talk. This one is personalized shock therapy, modern diagnosis and management of neonatal and pediatric surgical ICU patients. No conflicts of interest. This information, similar to others, was collected from multiple different training institutions, recent lit review landmark papers in the summer of 2024. And it's meant to add to the pool of data for someone training to take care of pediatric surgical critically ill patients, not necessarily to be the only source of knowledge. Checklist if you're in the Pediatric Surgical Critical Care Fellowship. All right, let's start off with talking about what is shock, going over definitions, causes and effects, monitored management, diagnosis, differentiation, as well as tracking resuscitation. All right, let's start with our basic definition of shock, which is a systemic inadequacy of oxygen delivery. It can be compensated, meaning that there is still maintained an organ perfusion, mental versus not. You may see hypotension and organ derangements, confusion, things like that. Definitions of sepsis. So SIRS, or the systemic inflammatory response syndrome, has fallen out of favor due to a lack of specificity. The joke being that you could be running a marathon with the flu and have the diagnosis of SIRS, or that it could be applied to just about any patient in the ICU. So we've come out with increasingly specific definitions. Sepsis 3, 2016 in adults, defines sepsis as a life-threatening organ dysfunction due to dysregulated host response to infection. So they defined it as infection plus 2 SOFA points. There's no more severe sepsis category, noting that sepsis by itself has a 10% mortality and so is already severe. Septic shock is hypotension requiring vasopresses and a lactate greater than 2 despite fluid resuscitation. In children, January 2024 was released the Phoenix criteria defining sepsis as suspected infection with life-threatening organ dysfunction, which is similar to the adult definition. The Phoenix sepsis score, which we'll talk about on the next slide, is becoming occasional required documentation for some insurance companies' reimbursement for sepsis and septic shock. What is the Phoenix sepsis score? So here's the table, where sepsis is a PSS score of 2 or greater in the presence of suspected infection. In septic shock, you have to get sepsis plus 1 or more points in the cardiovascular category. There is increasing mortality with higher points. And it does include a concept of the organ dysfunction having to be remote to the inside of the infection. For example, if you have pneumonia, you need the sepsis points to be in a different category than respiratory. What causes shock? We have 4 broad mechanisms, which you may already know: cardiogenic, including dysrhythmias, congenital heart disease, myocarditis, things like that; obstructive, including tamponade, pulmonary embolism, pneumothorax, abdominal compartment syndrome; hypovolemic, including hemorrhage, GI losses, etc. Hypovolemic and distributed will be probably the most common that you see. Distributed including sepsis, anaphylaxis, and neurogenic shock, which is different from spinal shock. Neurogenic shock being the cardiovascular derangements following a cervical or high thoracic spinal injury, and spinal shock being the loss of sensation and motor paralysis following a spinal cord injury with gradual recovery of reflexes. And you can also see mixed, for example, burns having both hypovolemic and distributive components. Shock in the setting of congenital heart ductal dependent disease will be discussed separately. Burns as well. Principles of hemostatic resuscitation following trauma is discussed in the Trauma 1 talk. What are the effects of shock? Well, if you don't reverse it, you start getting organ dysfunction and death, with studies showing that failure to clear lactate, for example, within 24 hours has a 7-time mortality in adult trauma patients, and in adult patients in the surgical ICU, the length of time before clearance correlates to overall mortality, and failure to clear at all by 4 days is 100% fatal in that population, in that study at least. All right, how is it diagnosed and how do we differentiate it in the modern era? So history and physical, blood pressure, obviously, pulse exam, skin perfusion, mental status, urine output. We don't use central venous pressure and SWAN as much for either volume status monitoring or shock. as a result of studies failing to show benefit Labs, the classic one, mixed venous oxygen saturation, which requires sample from a pulmonary artery. And again, we said we don't really use the SWAT anymore. But when you were getting it, you were getting these values, and normally it's in the 65 to 70 range. And if it was low, you had increased oxygen extraction, either from inadequate delivery of oxygen, from a state of shock, low cardiac output, etc., or from increased demand, as in hyperthermia or seizures. And if the SVO2 is high, meaning there's more oxygen in that venous sample than there should be, you either had super delivery of oxygen or some high flow state with failure, dysregulated oxygen uptake like sepsis or hyperthyroidism, etc. As CVO2 it became a surrogate for SVO2 after swans fell out of favor and no one was getting those anymore, but those similarly fall out of favor, and so these aren't really terribly monitored too much anymore. Lactate pH-based deficit, a little more frequently seen. You have all kinds of scoring systems, SOFA, Q-SOFA, the Phoenix sepsis score, and then particularly useful in the modern era for differentiation of shock is ultrasound, which will get its own separate talk, but we'll touch on some points here as well. Point of care ultrasound in critical care has many advantages. It's a quick augment to the physical exam, especially when there's significant limitations to the exam, which are fairly common in children. You'll see neurological differences, nonverbal, either whether that's from neurological differences or from their sickness or even just age. If they're sedated, intubated, or under neuromuscular blockade, similar challenges. Using point-of-care ultrasound, a trained provider can quickly look for all kinds of different forms of shock. You can look at the lung fields for pneumothorax or pleural effusions, signs of fluid overload. You can look at the cardiac windows to assess cardiac function, presence of pericardial effusion, and signs of tamponade. You can look at the abdominal windows for quantity, quality of free fluid, look for intestinal ischemia. You can assess vessels for possible cannulation for ECMO or central venous access. This, again, as I said earlier, it will be its own lecture, but needed to be mentioned here as part of the evaluation for shock. All right, well, we're going to talk about modern management of the main types of shock you'll see, which are hypovolemic, hemorrhagic, and distributive shock. This section will describe fluid resuscitation, fluid responsiveness, first line, second line agents for fluid refractory shock, and then as well as direct peritoneal resuscitation and some other more experimental things. The use of ECMO in sepsis, shock, and trauma are discussed in the ECMO weeks, which are up. Hemorrhagic shock. Stop the bleed, give the blood. As discussed in trauma 1, a whole blood's better if it's available, or 1 to 1 to 1 if not. And then you're done. You stop the. You're not done. The initial trauma, consequences, direct tissue damage, hemorrhage, hypovolemia sets off a damage inflammatory cascade, which eventually results in disordered inflammation, vasodilatory shock, and multi-system organ dysfunction if you're not able to stop it. So you have a patient that you're taking care of and you're worried about shock. Of course, you're worried that at the cellular level they have inadequate oxygen delivery. However, you don't really have that ability to see when you're standing in the room. What you see is the blood pressure. And although even brief intervals of hypotension, for example, in the operating room, are known to cause increased rates of acute kidney injury, cardiac, and other complications, often by maintaining the blood pressure, you keep happy brain, heart, and kidneys, but your efforts to treat shock and treat the mean arterial pressure result in other places in the body that are not as happy, the fingers, the toes, the splanchnic, etc. And that's what I mean by afterthoughts of shock. And here's a little case study. A 15-year-old transferred from a referring hospital where they've already performed a splenectomy, nephrectomy following an MVC. They've transferred him to you with an open abdomen after massively transfusing him. When he arrives, he's hypotensive, coagulopathic, and putting gross blood from the vac. You give him some more blood, you take him to the operating room, you ligate some of the short gastrics, for example, but when you get him back to the ICU, he's on multiple pressors, epinephrine, norepinephrine, phenylephrine. He's acidotic. You've done a pretty good job of giving him blood products. You've stopped the bleed, you've given him blood, and yet he's still in trouble, showing signs of shock with a lactate of 5.5. All right, let's assemble our superstar team. Hypotension, epinephrine, norepinephrine, Phenylephrine, by your powers combined, guts and fingers join us purple. And everyone's mad because your lactate's super high. First question that comes up when someone's in shock, fluids. Are we giving the right amount of the right type at the right time? And what happens if you give too much? How do we tell how much is too much? Which type should we be giving? What are our transfusion goals? Should we be using colloid, bicarbonate fluids, etc.? These will all be covered in the upcoming slides. First, what happens if you give too much? It's no big deal, right? Well, wrong. Here's a study, impact of magnitude and timing of fluid overload, showing that even relatively small amounts, what they defined as 10% of fluid overload, was associated with higher mortality and more days in the ICU, more days on the ventilator. And there have been a number of studies. The published one recently in the New England Journal of Medicine is the waterfall study for pancreatitis, which is starting to push back on some of the more aggressive fluid resuscitation algorithms for that diagnosis. And then SQUEEZE, which is not yet published but is in process, and is part of a number of studies with a swinging pendulum back towards fluid sparing strategies, in this case an early goal-directed fluid sparing strategy for pediatric patients in septic shock compared to conventional care. It's hard to tell though when a patient needs more. Evaluation of volume status and fluid responsiveness, meaning that our cardiac output will increase if you give fluid, is somewhat difficult. A physical exam, useless. Other markers, CVP, lactate, base deficit, not the greatest. Dynamic measurements are better than other tests, either blood pressure, ultrasound findings, for example, in response to either volume or a leg raise test. Ultrasound findings like IVC classibility and distensibility have not been completely proven in children. Better data for aortic flow velocity variability, which predicted fluid responsiveness in mechanically ventilated children with good sensitivity and specificity, but it's a little harder to measure. Similar almost to what was reported on some of the art-line monitoring systems like ProTrack, etc., that would report stroke volume variability. Incorporation of focused ultrasound, specifically cardiac ultrasound in patients with septic shock, changed the intensivist understanding of hemodynamics in 67% of patients in one study, and in adults using it for early goal-directed therapy in setting of septic shock resulted in improved clearance of lactic acid at 6 hours and reduced fluid volumes at 12 and 24 hours. And in avoiding that fluid overload is becoming more important. And in our ultrasound talk, we will talk about how to incorporate some of these things into your own exam. All right, let's go to transfusion goals. Transfusion in the setting of acute trauma is not lab-driven. It'll be discussed in the trauma weeks. Important to mention here that we also don't like to do permissive hypotension as a preferred strategy in pediatrics, which is explained in more detail in the Trauma 1 talk. Transfusion goals, here's for the NICU, which was also in the general NICU principles talk, and in that population there was no difference in outcomes with restrictive versus liberal transfusion threshold. In sicker older children, this is from these two references at the bottom. When deciding to transfuse an individually critical child, we recommend not only considering the hemoglobin concentration, but the overall clinical context. A definite transfusion for hemoglobin less than 5. A definite not for those who are hemodynamically stable with a hemoglobin above 7. And then in between those, we don't have data to make a recommendation. However, it's reasonable to consider based on the clinical judgment. In specific populations like trauma ECMO, we'll discuss during those respective weeks. Crystalloids versus colloids, a big point of recurring controversy. There are many different types of colloid. Albumin, starch, head of starch, which has fallen out of favor due to some increased risk of kidney complications. FFP. In general, colloid use similar to adults is not much benefit for most conditions. And NAPSCAN in 2018 for pancreatitis, for example, had no good evidence to support. With burns, there may be some better evidence, a possible reduction in overall crystalloid fluid infusions and reduced fluid creep. Neonates tends to be a little bit overused, with the seminars in fetal neonatology paper here saying really only to consider it for neonates with high continuous albumin loss, for example, from ascites or pleural effusions, etc., or nephrotic syndrome, things like that. Liver failure transplant might be the one area it's supported specifically for spontaneous bacterial peritonitis. Sepsis is a little less understood. Maybe it might be helpful after a large volume of crystalloids, and maybe in trauma after TBI, but data is less clear. Some folks favor intermittent bolusing over continuous infusion. Don't have much evidence for either. They say that it's more physiologic because you don't continually drink water throughout the day, you just intermittently bolus yourself. But for burn specifically, we prefer to do continuous infusions, which we'll talk more in detail during the burn week. But otherwise, there's not much evidence to favor either approach. When should we use bicarbonate? Should we use it whenever the pH is low? No. If bicarbonate acidosis is from, metabolic acidosis is from a bicarbonate losing process, then you should replace it. But otherwise, although you can raise the arterial pH, it does not necessarily translate to a favorable cardiovascular effect, and it may in fact have negative respiratory consequences from increased CO2 generation. And it may increase mortality as well in the setting of lactic acidosis. What are our current recommendations for pediatric sepsis resuscitation in fluids? And this may change after squeeze, but we'll see. Currently, if abnormal perfusion with or without hypertension is present, they recommend giving 10 to 20 cc kilo boluses until either the shock resolves or there's signs of fluid overload developing. They recommend balanced electrolyte solutions over normal saline, like things like plasma-light or LR, for example. They recommend against using colloid starches gelatin over crystalloids during the initial resuscitation, and do not have a specific recommendation for a transfusion threshold. How to assess volume. So we talked earlier about some of these techniques: passive leg raise, echo, stroke volume variation, aortic flow, velocity integral. There's a highly variable relationship between central venous pressure, blood volume, and volume responsiveness, and so CVP alone should not be used in isolation to predict volume status. There's this concept that instead of filling the tank, we should be working more towards shrinking the tank to a more physiological size, which is where some of the pendulum is swinging, for example, in pancreatitis or sepsis, is towards more vasoactive inotropic support rather than filling the tank with aggressive fluid resuscitation. Which should be our first-line agents for fluid refractory shock after hemorrhage or sepsis? Currently in children, norepinephrine and epinephrine are recommended over dopamine, with no clear evidence to support one over the other. And similarly in neonatology, no clear evidence to support one or the other. But they did note in that study, which was in Journal of Perinatology, a Nature paper, that there was reduced mortality with the use of hydrocortisone for septic shock, which is one of the reasons why we're going to see more uses of hydrocortisone in the NICU, and we'll talk later in the PICU as well. Other agents, after you've started your catecholamines, angiotensin II, vasopressin, methylene blue, vitamins, steroids, other agents, direct peritoneal resuscitation, and what agents or techniques do we have for rescue. We're going to go through each of these. So, angiotensin II came onto the field because we had a three-legged stool for blood pressure regulation with the renin-angiotensin-aldosterone system, having direct renin inhibitors for antihypertensives, but we didn't really have anything for anti-hypotension until this was brought out, whereas we had stuff on both sides of the anti and pro blood pressure equations for each of the other two legs, the vasopressin and catecholamine pathways. So it binds angiotensin 1A and 1B receptors, which increase intracellular calcium in the smooth muscle and activates the mechanism promoting vasoconstriction. Splanchnic vasoconstriction, importantly, is MAP limited. And so at lower MAPs, there'll be less splanchnic vasoconstriction. This agent received renewed interest for shock in the last 10 years. It was published in the New England Journal of Medicine in 2017, the Athos 3 trial, proving that it was effective at increasing the mean arterial pressure and reducing catecholamines. And it's hypothesized that it might help patients who have derangements in the renal and angiotensin-aldosterone syndrome, for example, possibly improve survival during a sub-analysis of that paper in patients who are on renal replacement therapy or high renin, meaning angiotensin deficient. It is expensive. We do have it here in Wisconsin, although I've actually not seen it used. Vasopressin, you've probably seen fairly frequently in the general surgery residency. Acts on V1, V2 receptors. The interesting part is that the effects are relatively well preserved in acidosis in contrast to some of our catecholamines, which do not work quite as well in acidosis and hypoxia. It has little effect on the pulmonary autoresistance. Recommendations for pediatrics are that it not be used as a routine adjunctive therapy, but may be considered as rescue therapy in patients with steroid and catecholamine-resistant hypotension. It's not been shown to have any mortality benefit. Titrating versus a fixed dose infusion seems to be an institution and provider preference, seen both, with no data to clearly guide one over the other. Methylene blue, an inhibitor of nitric oxide synthase and guanylate cyclase. And what effects does that have? Some papers say it reduces morbidity and mortality in vasopalutic patients after cardiac surgery. And other papers say it's actually an independent marker for morbidity and mortality, so not really clear its role. Similarly, for vitamin B12, some case reports saying improved SVR vasopressor requirements. Its role as a nitric oxide scavenger. We probably really shouldn't be using it unless you're in a research arm. Steroids, this is a big one, which has become under some renewed attention in the last year due to some recent guideline changes. So, initial studies, which are listed here, showed some possible mortality benefit in refractory vasodilatory shock if started early, with subsequent studies showing faster reversal of shock, organ failure, and became off pressors sooner, without causing increased infections or wound problems. So, here is some of that initial data with slightly improved survival curve. And you'll see in this box not an increase in sepsis or infections, nor specifically in the surgical patients, which were about 10 to 30% of the population, did you see increased rates of wound complications. So this was the update I mentioned earlier, which is a 2024 update from the SCCM. Although these results were technically only for adults, people, due to the lack of pediatric literature and the difficulty with doing pediatric studies compared to adult studies, have started to apply it to kids as well. So, what did they recommend? In septic shock, a conditional recommendation to go ahead and administer corticosteroids to adult patients with septic shock. They don't have a recommendation regarding dosing or duration, except a strong recommendation not to do a high dose short duration, which they defined as greater than 400 milligrams a day for less than 3 days. ARDS, again, pro steroids, as well as for community-acquired bacterial pneumonia. This is the study mentioned earlier in the Journal of Perinatology, where adjuvant hydrocortisone was associated with decreased mortality, and so these data are being applied in the NICU and PICU. We are seeing greater, more widespread uses of hydrocortisone, not just for septic shock, but for undifferentiated shock as well. What effects is that going to have on us surgically? Well, folks are always worried about leaking. What data do we have? We have papers all over the place saying it may or may not increase the rate of complications. Our most complete literature review from the American Journal of Surgery here is that the preponderance of human literature finds that high-dose corticosteroid administration less than 10 days has no clinically important effect on wound healing. However, in patients on it for more than 30 days, you do obviously see a rate of wound complications up to 2 to 5 times those not taking steroids. Other agents under investigation, some vitamins, thiamine, vitamin C, that have been looked at 7 times with no difference in outcomes. It seems like it's pretty easy to get funding to do that study. If you want to do that again, I guess you can. There's a growing notion, research interest in this thing called endotheliopathy of trauma burns, where the vascular endothelium becomes dysregulated, and looking at ways to restore some of that function with early fibrinogen or plasma administration with the use of syndicin 1 as a marker, but that's not yet reached prime time. DPR, so what is that? An adjunct for possibly sparing some of the afterthoughts of shock. It is infusion of warmed hypertonic saline into the peritoneal space. It was originally described by the maker of the Ranson criteria, Dr. John Ranson. In the modern era, it consists of peritoneal dialysate fluid, usually dionyl 2.5%, being instilled into the belly, usually at the root of the mesentery, and then that effluent is sucked through a temporary abdominal closure device into a bucket. What is the evidence for DPR? Why is it used? The installation of that warm hypertonic fluid into the abdomen seems to increase mesenteric blood flow. And that's one of the agent's techniques in this lecture that we mentioned that does that. Everything else seems to decrease spinal perfusion as a cost of maintaining mean arterial pressure. Evidence that this can also decrease visceral edema and have a faster time to abdominal wall closure with decreased rate of intra-abdominal complications, less time on the ventilator, fewer ICU days. There was some lower quality evidence that it may blunt the systemic inflammatory response, and as well as increase lung procurement rate when used for organ donors. Many of these publications are from a single center, which is the University of Louisville, and so take that into consideration. The initial evidence was in rats who were bled to 50% mean arterial pressure, then given conventional resuscitation with or without direct peritoneal resuscitation, and they showed that the DPR increased visceral blood flow and on histology decreased cellular and preserved tissue architecture better than just conventional resuscitation alone. They followed it up with human studies, initially in 20 patients undergoing damage control surgery, and they showed higher rate and shorter time to fascial closure with a lower rate of intra-abdominal complications. It was then the 2013 plenary paper, which was published in 2013 in the Journal of Acute Care Surgery, with 88 patients undergoing damage control surgery for abdominal sepsis. And again, they showed the higher rate and shorter time to fascial closure, fewer abdominal complications, large intra-abdominal infections, fewer ventilator days, fewer ICU days, with a trend towards lower mortality that did not reach statistical significance in their frequentist model. They also looked at it for trauma patients in 103 specifically human patients undergoing damage control surgery for trauma. Did not have significantly different volume administered to them. However, the time to abdominal closure was again reduced in the DPR group compared to conventional resuscitation, with lower rates of intra-abdominal complications, specifically lower abscess formation, and patients in the DPR group had a lower 30-day mortality rate despite similar injury severity scores. And here are their table data. This was some of the other data that I was talking about, showing possibly blunted systemic inflammatory responses, reduced markers of inflammation like interleukins, TNF, etc. And again, we see shorter time to abdominal closure, greater rates of primary fascial closure. Overall, intra-abdominal complications was less. This is largely driven by the rates of lower abscess. And here is their overall 30-day mortality, which reached a 0.07 level of significance in favor of DPR. This is some of that maybe evidence, again, with additional animal models and human cadaver studies. Some lesser studies that have been used for guild case reports, including 2 cases with necrotizing enterocolitis. So, who should be considered forward? And this is venturing into the opinion rather than the strictly level 1 evidence. Patients undergoing damage control laparotomy for hemorrhage or intra-abdominal sepsis in whom there's expected to be ongoing severe shock, especially if you're going to want to reverse any acidotic or electrolyte changes in patients who have compromised renal function. For example, you've done a nephrectomy. If they have areas of questionable intestinal viability and they're coming out on multiple catecholamine or other agents that will cause splenic vasoconstriction, this is one way possibly where you might be able to reverse some of that and have improved mesenteric blood flow if you have questionable areas of viability, for example, after a midgut volvulus. If there's heavy contamination, this might be used in between OR visits, as it's been shown to reduce the rates of intra-abdominal abscess formation, and then to get you to quicker abdominal closure. What about neck and gastroascesis? We're not quite there yet, but other conditions, like I mentioned, volvulus might be reasonable. Should we place DPR catheters into patients whose bellies are closed and not left open? Not right now. Rescue therapies. We have blood purification, which has got a lot of study using hemofiltrations, cytosorb, which is a filter with polymer beads used alongside dialysis to remove some cytokines, and therapeutic plasma exchange. The thought behind all of this is that there's excessive numbers of these inflammatory markers circulating around, causing a hyperinflammatory response, and if we can remove them from the circulation, we will do better. However, we just have an overall lack of quality data to support their use in septic shock, with references at the bottom you see here for each one of those. ECMO is a valid rescue for many different types of shock. That will be discussed in the ECMO weeks. All right, how do we monitor response to your treatments? Normalization of hemodynamics and end organ perfusion is a great one. Lactate clearance. SpO2 and SCVO2 have fallen out of favor with no clear benefit to monitoring. However, near-infrared spectroscopy, what we call NIRS, does have data, and again, it actually comes out of Milwaukee, that this might be useful, especially in cardiac patients. What is NIRS? Near-infrared spectroscopy is a useful non-invasive measure of end organ perfusion. There are different types. You can have a cerebral monitor, monitor on the flank, measuring the splanchnic bed perfusion. There's no clear critical threshold in absolute values, especially as there's different devices, but the trends can be important. I think the treatment of shock in the modern ICU has to be really individualized, with, of course, proline is needed if it's deficient, followed by any number of agents, whether that's blood if they have bled, fluids, maybe not that much, but maybe this much, with use of pressors, tropes in a fluid-sparing directed fashion, steroids becoming more in favor, methylene blue less so, with DPR or things like ECMO is for rescue therapies. Some recommended reading, here's one. You can also look at any of the other number of references that were cited in this study. Little quiz. Physiological dose steroids, A, are indicated in neonatal impaired septic shock. Impair wound healing, should be limited to a 3-day course, and require a long taper even for short duration use. And that's going to be this one. Match the evidence to the trial. Balanced fluids like LR are better than saline in sepsis. That would be prompt. Fluid-bearing resuscitation is SQUEED, which is not quite yet published, and the steroid is going to be this one. All right, to go ahead and calculate the Phoenix sepsis score. This is a 5-year-old with a suspected empyema with a MAP of 35. You can see that that puts you into the 2 points category, a GCS 11T. That gets you no points, INR 1.5. That gets you 1 point. Lactate of 4.9 gets you none, and a PA-FiO2 ratio of 350 might get you 1 point, but they want it to be distant to the site of infection, so you get 2 plus 1. All right, that concludes this talk. We'll see you next week.